Hi, good morning. My name is Dr. Clifford Deal, President of the Medical Society of Virginia. Welcome to the Medical Society of Virginia webinar update on surge capacity. We have today the Virginia Department of Health Chief Deputy Commissioner, Dr. Parham Jaberi, and Dr. Vanessa Walker-Harris, the Deputy Secretary of Health and Human Resources. This is a CME event, so there's a blurb I have to read about that for CME purposes, no commercial support was received for this activity. There are no reported conflict of interest for an individual in a position to control the content of this program or speakers presenting on the program. We are recording attendance and will submit to VCU for CME following the webinar. VCU will issue a certificate to you at the email that you registered with. Before we start, I'd like to remind everyone that the MSD and its staff has continued to work very hard to pull any and all relevant materials related to COVID-19 on our website at msd.org/COVID-19. We will post a recording of this call on the webpage later today, should any of your colleagues want to listen who are not able to join us this morning. We have a large number of people on the call this morning. We understand there'll be a lot of questions. Please use the chat function on your computer. We ask that you try to keep your questions focused on essential healthcare providers and services and surge capacity, alternate care facilities, and COVID-19 modeling. If we don't get to your question by the end of the call or have another question, please email us to the MSD at governmentaffairs@msd.org. With all that being said, I'd like to welcome first the Chief Deputy Commissioner, Dr. Parham Jaberi.
Good morning. Thank you, Dr. Deal. I appreciate everybody being on. Again, my name is Parham Jaberi with the Virginia Department of Health. My day-to-day oversight is over our regulatory programs, environmental health, drinking water, rad health, but also over the Office of Emergency Preparedness. By background, I'm a preventive medicine physician. I went to Tulane to do my residency, and it was in those years when Hurricane Katrina hit. So while I had gone into public health, really thinking that down the line I would be working for the CDC, looking at infectious diseases and movies that had stimulated all of our interests back then, like Outbreak, was really what was in my mind. And as I was going through training, I saw certainly a completely different angle of emergency preparedness, the values that can bring. Can we go to my camera before I flip onto the screen?
Taylor, can you switch over to Dr. Jaberi?
Yes, he has access to share.
Oh, okay, I see.
Perfect. You're there.
All right, thank you. So, during that time with Hurricane Katrina, realizing the role of public health, of the decisions we're trying to make with the public, and who is that? Obviously, we're doing everything we can to help with the citizenry, but really, we can't do our work effectively and help the patients, whether in a disaster or whether on our day-to-day work, without your help and without your support. So when we talk about a public health emergency, we're really invoking all that we have, all the powers that we have, and all the partners that we have to respond. And certainly with COVID-19, we're seeing this as being one of the largest, most complicated response efforts we ever have, as we're seeing a public health issue, and now all the ramifications, economic issue, we're seeing social behavioral changes. And it is something that, while we have had some experiences with, some very valuable lessons learned during H1N1 with regards to how do we address a pandemic, some very valuable lessons learned even from Ebola about tracking patients coming in from outside the borders into our country and doing a very, very exhaustive contact tracing. We'll bring all those efforts and resources together, but certainly this is a situation as it's evolving. We found this conversation with the Medical Society of Virginia. I believe my other colleagues have been on, Dr. Peak, Dr. Vola, Dr. Remley, and the other conversations had with the specialists, including a call last night, have all been very, very helpful in informing us of what's really going on the front lines and how best we can continue to grow and adapt this response to the needs of Virginians. So my thanks again to all of you. This is a group effort, and certainly appreciate all that Medical Society of Virginia has done, both in allowing us to share some public health messages, as well as attending on our weekly calls. When we began this campaign, we set up a unified command through the Virginia Department of Emergency Management, drawn on various state agencies, on various healthcare coalitions and entities. And we provide various updates through our Healthcare Coordination Committee. It's a call that's hosted through the VHHA on Tuesdays at 2 o'clock. The Virginia Department of Health does a briefing for all partners, whether it's community, local government, folks in emergency management at 10 o'clock, and certainly if others would wish to hear more from the Public Health Department, feel free to contact us, Susie.Silverstein, Susie, SUZI.Silverstein at vdh.virginia.gov is the organizer and can add you onto that list. But these morning hours allow us to be more specific to the needs and questions of our members at MSV. And just thought, as most of you have probably identified already, wanted to show just a couple quick screenshots of how we begin our day and what our overall situational awareness is. Then we'll go to Deputy Secretary Walker-Harris to talk more about the topic at hand, about essential services. That's a very important question we've been looking at, especially with the stay on elective surgeries, procedures. What does that mean? And then to come back to me to talk a little bit more about what we're thinking and planning for a potential surge in our acute care facilities. So just to start, to set the table, Dr. Deal, is my screen now visible?
I can see that it says the COVID-19. It's just the title slide, but not your screen. This COVID-19 that you're seeing, I was hoping to show the web page for the Virginia Department of Health. Is that visible? No.
Okay. Well, I will just go ahead and cite some of the numbers. I apologize for the confusion on my part. So every day on the and folks can visualize these numbers if you go and Google VDH and coronavirus. It'll bring you to our COVID webpage. We have a total cases of 6,889 in Virginia, and this is updated daily. As this are numbers as of yesterday, today our numbers are likely to go above 7,000, and the total deaths of 208. That brings our mortality rate currently to about 3.0%. If you look at the CDC numbers, which are nationwide, we have a total of 632,000 cases and 31,000 deaths, mortality rate of about 4.9%. And on the CDC website, it shows the regional variation and what we're beginning to see, the pockets of density of cases identified early on in Washington State, in California, in Florida, in Louisiana. And now we're seeing those pockets extend. So now Texas has a high number. And from New York, we have progressed on to New Jersey, Pennsylvania, and Maryland as those higher rates of density. So obviously we're seeing this northeastern corridor lighting up on the maps. And as we're looking at what that means for Virginia, and Lauren, you can just go ahead and go to my camera if you wish. What does that mean for Virginia is that we're beginning to see our earlier peaks, our earlier pandemic curve impacting Northern Virginia at a slightly higher rate than other areas of the state. In addition to the Virginia Department of Health webpage, there's also the VHHA webpage where we talk about the number of patients that have a confirmed COVID positive case. They just built this dashboard, and I would highly suggest seeing it for those who are hospitalists or want to look at the acute care capabilities. We have talked a lot about, obviously, the capabilities when it comes to ICU beds and ventilators, and so all of that is available on the VHHA website. Just to give a very brief reciting of the numbers. So the total number of people currently receiving inpatient hospital care whose COVID-19 tests are pending is 537, and those who are confirmed positive are 800. So we're looking at roughly 1,337 patients actively being treated or cared for in our acute care settings for COVID. The combined number of confirmed positive cases of COVID whose results are pending and in the ICU is 427, and those who are currently on a ventilator is 238. So this is an important number, as you all know, when we were looking at some of our planning factors and looking at mobilizing what we have in the strategic national stockpile. A lot of questions and concerns on our capability and capacity when it comes to ventilators. And what we're seeing in Virginia, we currently have roughly 2,840 ventilators, and the total use as of, again, today is about 700. That's roughly 25%. So we currently have a significant amount of capacity as a whole in the Commonwealth when it comes to total ventilator use. And bed availability stands about 5,500. So the good news is that currently in Virginia, we have not had to utilize any or need any resources beyond our current need. So while we have done quite a bit of work around PPEs and some measures put into place to help conserve, reuse, when it comes to our critical assets, ICU beds, ventilators, we have not gotten to the point where we have to make any sorts of decisions with regards to allocation of scarce resources. However, that doesn't mean that that will not be potentially something that we are looking at down the road. So after Dr. Walker-Harris presents some of her slides, we're going to come back and revisit where we are and where we may be headed potentially into the summer months. So just to kind of give a snapshot again, we stand at about 7,000 cases, 3% mortality rate, and a good amount of capability in our acute care settings, both in terms of number of beds, in terms of ICU capability, and ventilators. I'm going to throw it over to Deputy Secretary Walker-Harris to talk a bit more about our essential care services and how the executive orders passed by Governor Northam has impacted some of our current planning and what we may be looking at in the coming weeks. Dr. Walker-Harris?
Thanks, Dr. Jaberi. Good morning, everyone, and thank you to MSB for organizing this opportunity for Dr. Jaberi and I to provide a brief update on the work that we're doing in responding to COVID. And again, echoing Dr. Jaberi's thanks to everyone on the call for being such great partners as we all work to respond to this challenging time. So what I wanted to do was just provide a little bit of background and overview related to the Order of Public Emergency number 2, which outlines the prohibition on non-urgent procedures and surgeries that was instituted both by the governor and the state health commissioner on March 25th. We can go to the next slide. So I'll just outline the order and then kind of walk through what a number of us were thinking about essential healthcare services and essential healthcare providers. Those two terms are not used explicitly in the order, but they're very related, because once you start thinking about the services or provide that you can't do, of course you're thinking then like what is in scope, what is it that I can do, and then which are the providers that are considered essential for these purposes. Next slide. So I have my date wrong, but on March 17th, the governor and state health commissioner issued the Order of Public Emergency, which prohibited licensed inpatient surgical hospitals and freestanding endoscopy centers and other care settings from providing surgeries that require personal protective equipment that, if delayed, were not anticipated to cause harm to the patient and provoke a negative outcome. And so really this was motivated by our understanding of statewide needs related to personal protective equipment, both the supply across the supply chain, and as most folks are aware, across the nation, the supply chain for PPE has been quite a challenge. Virginia got about 3 allocations from the Strategic National Stockpile, but they did not exactly match up with what we had requested. And then we've been working with a number of partners in order to source additional PPE, but keeping in mind that the supply chain for PPE has been quite a challenge. And then we have a number of demands, which include the healthcare system, but expand beyond the healthcare system to a number of our frontline workers that are quite essential during the COVID response, as of those who are in other congregate settings like Department of Corrections, and are those who provide services in Department of Social Services or other human services like our adult protective service workers who also need to be able to do their job safely. So thinking globally, statewide about PPE and understanding the tremendous challenges we were facing with sourcing and responding to the requests from health centers, localities, our community providers. We instituted this order in order to be judicious about the use of PPE and conserve PPE. And Virginia was very much in line with what other states were doing at the time. And we took a lot of lessons from other states and how we crafted this order from Washington and other states. So things that are exempted or not included in this order include, of course, anything that if delayed or canceled would result in the conditioning worsening. And so really relying on the clinicians' best understanding of their patients, their diagnosis, and their potential clinical course in order to decide what is in or out of scope. And also anything care that's delivered in an outpatient setting in the hospital-based clinic was exempted. And then the full suite of family planning services were exempted from this order. Next slide. So in order to provide a bit more clarity around the order, Dr. Forlano, the Deputy Commissioner of Population Health at DDH, and the branch chief for our COVID-19 branch for our COVID response, and I gathered some of you who might be on the phone, a number of our partners in MSP and other community-based clinicians and healthcare professionals to think through essential healthcare services and essential healthcare providers in order to provide additional guidance out to the healthcare community. It's in the form of an FAQ, and I'm working on getting that posted for folks to review, and which would serve as additional guidance and support as you're making your decisions. But some of the things that we thought through, it would be hard to come up with a laundry list of essential services along with essential providers. And so we took the approach of just providing some general guidance and try to align that with what national specialty societies were recommending and were advising to their members. And so things that we held in mind were that even during this time of emergency response, some things are really still necessary to continue, like preventive care and wellness care. And then there are some modalities that we're familiar with that are going to need more, like telehealth. And so some of the underpinnings of our discussion were that essential healthcare services are those that really ensure the continuity of care. So during this emergency response, we might be providing that care in different ways based on our access to resources like staffing and supplies like PPE and space. And then through this, as Dr. Jaberi mentioned, and I've said as well, we really have to take careful account of those resources when we're providing these services. So that includes the PPE, the staffing, and then what your milieu is related to COVID. So are you in an area that has current outbreak, and then how might that impact what services you provide based on what your community members' risk and what your staffing risk might be. And then maximizing telehealth. And I know Dr. Ruban and Dr. Reddy from DMAS have provided some other updates on similar calls about all the work that's being done now to help folks who might be new to telehealth get onboarded to telehealth and use that as a useful modality to provide care in a different way during this time, so that we're making sure that our patients are healthy and well, but keeping them out of the physical health system if that's not necessary. And then what we've done at VDH is taking a look at what's out there in other states and through specialty society guidelines. And the specialty societies have done quite a great job of providing guidance that's specific to their specialty and really changes in real time. And so instead of us coming up with things that are specific that might be out of our own professional scope, we're really depending on the specialty society guidelines like American College of Surgeons, and AAP has really good guidance about what types of services should and could be provided in an augmented way during this time. Next slide. And then for essential healthcare providers. So this designation may impact some folks more than others based on what benefits might be available based on that particular designation. So it's pretty straightforward to think of our healthcare professionals as essential healthcare providers, but then within that whole umbrella category of essential healthcare providers, who should remain open and what kind of care should you be providing then? So as I mentioned before, we really do believe and agree that preventive care and wellness business during this time are still quite paramount. And then of course, providing urgent and emergent care that helps people avoid those higher risk settings of care, hospitalizations, and urgent care visits. So doing the floor triage, pre-hospital, as best we're able with these different modalities like telehealth or using the phone or those types of resources. And so we also recognize that essential healthcare providers aren't just in the hospital, but they work in a variety of medical, public health, behavioral health fields and facilities across the care continuum, from primary all the way to quaternary care centers, and believe that everyone has a role to play in this continuum of care from preventive to urgent and emergent care. And then if folks are looking for additional guidance, a list per se of what's considered an essential healthcare provider, the Cybersecurity and Infrastructure Security Agency, and that's the Department of the Homeland Security, a contingent of the Department of Homeland Security, has developed guidance related to essential critical infrastructure workforce, and they have a whole section related to healthcare and public health that's pretty specific and covers things in more detail down to the laboratory worker or persons who are supporting the hospital effort, and that type of detail if there's a need in your institution to provide additional clarity on who's an essential healthcare provider. Last slide. And so if there are any additional questions related to this, I'm very happy to entertain those. I did want to state that we're carefully thinking through this order now, realizing that it's set to expire next week on April 24th. And some of you may have been involved in those discussions with Dr. Karen Rimley, as Dr. Jaberi mentioned. We're considering the same factors that led us to this decision to begin with. So what is our status on PPE, both the statewide supply and the demand? Keeping in mind those health centers that's in the global demand across the state, from frontline workers who may not be in the healthcare system but still have a need for PPE. And then our testing capacity as well, which impacts PPE demand, because as we increase testing, there'll be an increased need for following those CDC guidelines and keeping folks who are collecting samples appropriately safe. So we're getting information from our health systems and community-based providers to help inform next steps related to the order of public emergency too. Thank you.
Thank you very much. Appreciate that. Dr. Jaberi, we're gonna go back to you now.
Yes, please. So just and I apologize. I want to make sure that folks can see my screen. I'm going to share a PowerPoint that was provided by our UVA colleagues at a press conference on Monday. Is my screen visible?
Not yet. We can see you, but not yet.
All right. Let's see.
While you're doing that, I'm going to remind all our callers and listeners that the chat function is live on your computer. So if you will ask your questions, I'm getting a couple of those. We will engage the panelists. There you go. Perfect. Parham, you're in.
All right. I've kept to the original presentation, but I'm only going to highlight a few of the key slides. Again, this presentation was by UVA, some of our colleagues who helped put this together with a great amount of background specifically in analyzing infectious diseases. This is only one model. We've looked at certainly a number of others, but I have used this in my talks over the last couple of days as they had some very key visuals that really explain where we are and why we're going back and forth with regards to these executive orders. How long do we put a stay on elective surgeries? And I will go straight to those slides in just a second. So realizing just as a whole that one of the reasons we like the Virginia model is that it calibrates based on new information and factors that come in. So as we look at social distancing, we're beginning to see that we're starting to bend the curve, whereas 3 weeks ago we were doubling our cases almost every 3 days. Then the following week we were increasing by about 70%, 50%, 30%. So while we see each and every day that the numbers are going up, the relative proportion of number of cases going up is not as much as before. So we're bending the curve, and this model takes into account those kinds of considerations. It looks at outcomes such as those were confirmed with illness, hospitalized, ICU, ventilated, and death. And as I shared with you at the beginning of the conversation, these are all parameters that we now have publicly available on the VDH website, the VHHA website. So other folks who are doing modeling can also take a look and make their own interpretations. The biggest takeaways of the presentation for the governor really this week, and the message we were getting out to our communities: currently social distancing is working. Just personally, I've really been not surprised, but really taken aback by how great, in fact, how effective this measure has been. Just a few weeks ago, we were worried about running out of hospital beds by early May. We were worried about overwhelming our capabilities, and that was looking at models where we were looking at more of the exponential increase of cases to occur within 5 to 6 weeks of the initial outbreaks. And as you all know, and as I mentioned early on, we are nowhere near that. We have been very successful in flattening out the curve. So again, while we're seeing an increase of cases every single day, it's a small proportion of the day before. We're not doubling every 3 days as some of the early models had suggested had we not taken any of those measures into account. So we are thinking about, what does it mean if we lift social distancing and looking at other models to help further inform our conversations. But I wanted to get to a couple specific points. Mention mainly that with the UVA model, one of the other things they do is not just look at the state level, but really look at the community level. And without going into the graphics, this is the interactions of those who are susceptible, exposed, infected, and recovered, where they take into account what's going on in Virginia at the county level and help inform their model to provide us better predictions. Some of the key points is that the parameters that we're looking at is the reproductive number. You all have probably heard about this. So for every case of COVID-19, how many other individuals we believe may become infected, and that's just a little over 2. The infectious period is about 3.5 to 5 days. And the assumption here is because testing has not been widely available, and this is certainly an important variable that others may have differing opinions on based on capability. And as Dr. Walker-Harris alluded, this week we're actually seeing much more abundant supply of testing. And so while individuals were waiting for about 4 to 7 days potentially for a turnaround time, we've reduced that to down to 2 or 3 at most. So whether you go through the state lab or private labs, and I'm curious to hear what folks are seeing out in the field, we have reduced that. And so we hope that by increasing our testing capability, that detection rate goes up. But when UVA provided us models, they were saying we're probably not picking an overwhelming number of cases because either asymptomatic, or they have symptoms that are so mild, or they may recover before they actually get a test. The key points to their model was, and this was again produced for the governor to help him decide whether he wishes to extend the stay-at-home order or not, was had we not done anything different, and basically after the initial executive order would have come to a close on April 24th, what would we have seen as of April 30th? And what would we have seen potentially if we continue with the isolation orders well into June? So that the two terms that they use is a slowing of illness, which is what we saw, means that there was still a continued increase in the number of cases each day. However, we see that social distancing is able to level that increase. And then pausing is really when social distancing goes to extreme effect, where we're literally able to see a stop in the increase of cases. And so we're actually on a negative decline. So while we're seeing an increased number of cases, the rate of increase, or that slope, has decreased. So we're starting to get towards that pausing phase where we are really preventing the additional propagation of this illness in our communities. And so when we look at the models, rather than just looking at it as a slowing or pausing, our UVA clinicians really helped us understand why more than likely it's going to be something in between. Some of the parameters, and I share this only because of some of the feedback I received on other calls this week and hearing firsthand what's going on in our hospitals, is that some of the assumptions here, obviously transmissibility, incubation period doesn't change, but they took into account the proportion hospitalized, proportion in ICU, and what we're beginning to see is perhaps we're getting smarter with the care or additional clinical knowledge that's coming into Virginia, is that some of our hospitals are saying, you know, our proportion in the ICU is now less than 20%. The proportion ventilated is significantly less than 70%. Hospitalization to ventilation duration hospitalized, that was one of those key numbers. So the longer you're hospitalized, the longer time, obviously, you're taking up the resources and potentially spreading the illness to others in the acute care setting. That has reduced from 10 days. So while we're still looking at the initial numbers, a lot of anecdotal experience coming in saying we are getting better at treating this illness. Our detection rates are going to increase. So there may be some new models that could better help inform where we are. But given what we know, and I'm going to go ahead, they basically showed how they're using our clinical data to show you this key graph. This key graph, the gray bar is unmitigated, as in we would have not done anything upon the initial diagnosis of cases here in Virginia, and we would have seen that classic exponential growth curve in the gray. And you can see that roughly by this time, had we not taken any measures, rather than having a few hundred cases a day being added to our incident numbers, we'd be looking at 3,000 to 4,000 cases a day. And so we have completely veered away from the gray curve. Initially, with some of our efforts to slow down the illness, whether through, again, closing schools, closing colleges, and encouraging individuals not to go out in mass gatherings and limiting the number of individuals eating at a restaurant to 10, we were trailing more along the slowing of this illness. So cases were still increasing, but we had taken some very effective measures. And then in the pink, you see that, you know, not only did we slow the illness, but we're actually looking at more of a flat line increase as we go into the late spring and early summer months. So while we haven't completely stopped the transmission of illness, we have seen that we've been very, very effective in reducing the rate of spread, really flattening out the curve. So what this means is that as opposed to having an initial peak that we had initially talked about in Virginia of overwhelming our hospital beds and our acute care capabilities by early May, as you see in the gray, we've effectively pushed those peaks back. And what you'll see in terms of the green and the orange lines is, again, had we just done some social distancing, closed schools, closed some of our non-essential facilities, but not taken the stay-at-home order, we would have potentially seen peaks in late May or early June. But the current projections are, if we continue this well beyond well beyond May and then all the way up to June 10th, which is when the other executive orders expire, we could potentially push this peak of our surge back into late June or July. And so the conversations that are being had and what Dr. Walker-Harris shared and what you're hearing at the federal level and the state level is, yes, we can be very effective in stopping the growth of this curve. We can be very effective in preventing potentially going above the surge capabilities of our hospitals, but at what cost, at what economic cost, and at what other health impacts? How long can we really afford not to do our elective surgeries, our elective cases? And what we're hearing anecdotally, even through my office of EMS, is the number of calls that are going out is drastically reduced, even for cases of patients suffering from stroke or MI, is that the people are seeing those early warning signs and not really seeking care because they're afraid to go into a facility to seek that care. They're afraid that if they're admitted, they may potentially get COVID. And so we are beginning to see some obviously unintended consequences of this very drastic measure of the closures. So we're looking at all these models together and trying to inform where we're headed. What this means in terms of our alternate care facility planning, and the governor addressed this in one of his press conferences, we were looking at providing additional capabilities to our acute care facilities, looking at these large convention center style areas of care, the Dulles Expo in Northern Virginia, the Richmond Convention Center here in Richmond, and the Hampton Roads Convention Center, because initially we were worried about going beyond that that capability for hospitals, but right now it looks like those peaks have been pushed back into the summer months. And depending on how successful we are in flattening this curve out, again, through our social distancing measures, through obviously the closures of schools, businesses, we are looking at what is it that we really need. Would those large convention centers really be the best way to go? Or do we need more mobile, agile units? And the reason we're talking about that, as you all know, is that the greatest number of deaths right now is occurring in our long-term care facilities proportion of deaths. We're worried about similar sorts of things occurring in our prison populations, our offender populations, and other congregate settings. So the question is now beginning to shift, is even though we have been very successful in protecting the surge capability of our hospitals and have a good amount of supplies to take care of patients who need ICU care or ventilation, what can we do and what should we be doing to focus on some of these other high-risk settings? So for the sake of time, I'll end on the slide just to point out the fact that regardless of what model you use, and in this particular slide, this was showing that we really have social distancing in effect till June 10th, going hard and strong. And given the wave that we've seen from the Northeast and our initial cases occurring in Northern Virginia, we're likely to hit our surge capabilities if we let go of all of those measures sooner in Northern Virginia than in other regions. And so this is just one graphic to share with you that on any day, whether we're talking about PPE capability, testing capability, bed availability, we realize that the picture is not the same across Virginia. And so we also want to, whenever we talk with our communities, is we want to provide as much flexibility for our local healthcare providers or emergency care professionals to make the decisions that's best for their regions. But at the same time, we're trying to think about, as a state, when we invoke certain executive orders or certain guidelines, we really think about equity. We really think about, well, if we were to be potentially overwhelmed in one area of the state versus another, if there are resources in other parts of the state that's still available that can perhaps be used to offset those needs. So we're trying to think as a state as a whole. We're trying to think on a regional basis and really trying to make the best decisions along with our partners and input from hospitals, from partners such as yourselves, to inform our next steps. Let me go ahead and end on that slide. Again, just thanking our folks from UVA for the work that they're doing. And again, this is only just one model that we are looking at in Virginia. And certainly love to take your questions at this point or any other feedback you may have with regards to what you're saying regarding testing capability or questions about surge planning. Thank you, Dr. Deal.
Parham, thank you very much. Appreciate it. Let me ask you, a couple questions are coming in about other models. Can you just briefly describe, we all look at meta studies, for guidance clinically. Can you tell us about the other models and how that impacts your decision making?
We looked at the CHIME model and the IHME. Really, all of those were taken into account. And at the end of the day, what I would share in terms of really the last part, rather than speaking to the models themselves, is all of them were presented. And what we have tried to do is try to give one consistent picture for the Commonwealth. So I know that a lot of our partners in the hospital community were looking more at the CHIME model. Some of them speak better to predictive capability within the acute care setting. What we really like about the UVA model is it takes a lot more things outside of the clinical picture and looks at the variables within the community. And while I didn't really go into depth, the conversation there that an individual may work in one county, live in another, and be diagnosed in a completely different county, and with the movement of that individual and the interplay at hand, how does that affect the overall picture? And so we felt the UVA model provided a little bit more of a granular visibility of what's really going on here in Virginia. Again, I'm not the expert, but would share that those models, again, there is no one right model. There's one that we're preferring to keep the story consistent, but all of them really have their own uses depending on your specific setting and your specific vantage point.
But it still looks like we do hit a surge on all those graphs.
So the surge, you know, is consistent. If you recall the initial graph with the unmitigated curve, that we've not done anything, it's roughly 5 to 6 weeks. If we open up all the businesses, go back to life as it's been, with the potential continued increase of cases, it's 5 to 6 weeks. And so all of those graphs assume that after April 10th or after April 30th or June 10th, we go back to life as it has been. And we don't think that that's necessarily going to be the case. What we're hearing is that there would be a phased opening. I know the federal government presented on that a little bit last night, and I imagine those other governors would likely follow suit, in that we would probably go back to saying what are the most essential services. And so the discussion that Dr. Walker-Harris really opened up with the medical community is, how do we go about that? Do we go back to all sorts of visits, all sorts of elective surgeries, or is there a way that we could phase that approach? We're fortunate in that we're beginning to go into the summer months. So the question would be, do we keep all the schools closed and just resume operations in September? Will there be other offerings, certainly through our higher education, other congregate settings that would potentially impact that curve? And so really, that curve goes up, assuming that we go back to life as it has been. But the real answer will likely be somewhere in between, where we may see an increase in cases as we do open up some businesses. And what we're going to be looking at a state is, obviously, if we begin to creep up towards that cap of our surge capability, we have had the discussion that we may wind up clamping down. And so as you talked about the model, some of our cabinet members talked about a potential clamping on and clamping off, allowing some folks to go back to businesses, resuming certain operations. And if we see that the numbers are trending towards our limits of surge capacity, we may have to clamp back down.
So one of the questions that's coming in is about testing. It's just, is there any resource to help folks in private practice obtain the CellX rapid testing so they can better proceed with in-office surgery or surgery center procedures?
So what we have done in the state, more specifically, has been focused on a set of guidelines to really triage those that have the greatest need for testing. Those are symptomatic and high settings, healthcare providers. We have really looked to our providers out in the community, specifically after we talked about, some folks talked about the state and the CDC's testing criteria perhaps being too restrictive. We allow the providers, the clinicians, to really have that full gamut and full clinical judgment of whoever needs testing to be able to get the sorts of tests that they need. So part of this question is, in terms of specific resources that the state would provide, none that we have additionally to share. But what we are beginning to see is that there's increasing capability through our private sector. So working through the hospital systems and working through I don't want to name particularly the big two, but that comes to mind, Quest, LabCorp, other individuals, is that they're beginning to increase their capabilities as well to be able to use those providers. What we're also beginning to see in the state and nationally is a lot of companies coming out with new testing capabilities, and not all of these are necessarily FDA approved. And so there may be resources out there that could be potentially used, but we're not in a position at the state right now to endorse those products. So I think, again, the best course of action is to use the relationships already there with our private partners if providers want to increase that capacity. I know Dr. Walker-Harris was involved in some of that conversation. Let me see if she wants to add anything further to that as well.
You know, I would agree that with particularly like the antigen antibody testing that is still being evaluated by the CDC and FDA, and we're looking forward to reports that are supposed to be coming out this week from Mayo Clinic and other researchers, so that we have greater confidence in some of the tests that are soon to come onto the market. And those are definitely areas to explore. And we know there's great interest in point of care testing, but that's an area we're still learning about, as Dr. Jaberi said. But we're very excited that the capacity for testing is increasing, and definitely always welcome feedback from those of you who are needing this in your day-to-day, so that we can understand better what opportunities we need to continue to explore.
Thank you, Dr. Walker-Harris. One of the first of all, in case I forget to mention at the end of this, thank you all both very much for coming on our program this morning. Our webinar has been really especially helpful. I'm getting a lot of comments that are coming across the screen, so I want to say thank you. One other question is coming up about just about the quote, the second wave, and that there were a couple of waves in 1918, and of course we can't but so much predict the future, but any comments about that?
Sure. I think in the context of surge planning, the question is this virus going to, two really thoughts here is, as we think about the slowing and the pausing, is as we resume our normal life, will we then see that first natural peak? And then if that goes away, if we're able to limit that spread, and there's some theoretical conjecture, we're still getting more information on the impact of warmer climates, warmer temperatures, of what that means is, do we potentially see a resurgence as we normally do with other coronaviruses in the late fall and winter months? And so from a planning perspective, that's certainly in the back of our minds, and whether it's the same virus that winds up infecting those that are still susceptible in our communities, or whether this virus potentially mutates and is able to reinfect, in fact, those individuals who may have already been infected in the first wave. So there really isn't clear guidance, as you noted. So from a planning perspective, some of the things we're thinking about in terms of surge capability, in terms of replenishing our strategic national stockpile, in terms of taking advantage of whether we're able to secure more personal protective equipment, certainly improving our testing capabilities. These are all things that will definitely help in the second wave. And so we're trying to do what we can to be better prepared as a state, as a Commonwealth, should that need arise. At this point, it's still, we don't really have a clear idea, as you mentioned, Dr. Deal, of when and how that second peak may arrive. But given the previous history with previous pandemics, is that we have seen that we're making some necessary preparations, again, in terms of preparing and having on hand, again, PPEs, testing capabilities, so that we could be much better on the front end. I think as all of your providers know out there, one of the early things that we could have done probably a little bit better had we had the right supplies and equipment would be to be more aggressive in our testing and contact tracing. So if we're able to have that, if we're able to identify pockets of illness, we're able to work our public health measures more on a local level with regards to potentially community containment than going out statewide. So I think if there is a second surge, we'll be much better prepared to address it quicker, more efficiently, and we'll just have to wait and see at this point.
Thank you. A couple questions coming in and we've seen this in our own communities about how many healthcare workers, particularly physicians or nurses, are are being affected with community spread. But the follow-up question to that is, how much transmission are we seeing within the hospital system from patient to provider or to nurse or lab tech?
Right. I had I'm gonna say this with some pause. In one of the meetings yesterday with the hospitals, one of them mentioned that they had a case of where one of the nurses had become acutely ill, and they did have some additional testing available, so they did a surveillance within a particular work unit. And so the rough number that I remember from that is about 80 some folks were tested and 8 individuals came back positive. And through questioning, when they went back to those individuals, some said, I kind of recall a headache. I recall not feeling really up to par. And so it was roughly 10% of the healthcare providers in that particular unit that had tested positive. In terms of globally statewide, I'm not sure if I have those numbers or if our Office of Epi collects those of the 6,900 folks as of yesterday that had reported what percentage are healthcare providers, but we certainly see and realize that in those areas such as the long-term care facilities where we are doing more prevalence testing and where we have seen healthcare providers becoming ill, it remains a significant concern. So I don't think I have the rates yet in terms of healthcare providers becoming ill as compared to the general population, but we know that healthcare providers are a category of increased risk. So we would expect that the rate of illness in that population is going to be slightly higher than those of the general population, just simply given the potential exposures that they may have.
Thanks much, Dr. Walker-Harris. This might be a question for you. One of our listeners is commenting that some private payers and TRICARE, although I know we don't control TRICARE, are still not paying for telehealth at Parity within office visits, and any way we could address this.
Sure, happy to. I don't recall TRICARE stance specifically. I know that Medicaid has done quite a lot at looking at their policies and how to make that as flexible as possible for telehealth. And a number of the private payers are commercial partners as well, in making sure that there aren't barriers for either providers or for members in order to access telehealth. But I'm not recalling TRICARE offhand. And I know that MSV has done an excellent job of providing resources on your website for your members about what each of the insurers are doing related to telehealth. But I can look into TRICARE and provide some feedback back to MSV.
That'd be great. That's another testing question just about the sensitivity and specificity of the VDH test for COVID-19.
Dr. Deal, this number escaped me right now. I should know that. I apologize.
Sorry, you're doing a lot for us.
My mind has been so much in the search capabilities. In terms of the sensitivity, some of the anecdotal reports that we have gotten more recently is that that we may be getting more false negatives than initially presumed. So given the change that we've seen, I'll make sure I'll get back to you on that. That's a very, very important question.
A couple of the, Clark, this is really an MSV related thing that to make sure we have the UVA slides. This webinar, again, is being recorded and will be on the MSV website later on this afternoon. And we will work to get Deputy Secretary slides as well as Dr. Jaberi, the UVA presentation slides, also available on the website. All right, let me turn back to
we can do that.
Good, Dr. Jaberi.
That wasn't me, it was someone else.
So I think we're wrapping up with most of the questions. There's some specific treatment questions I'm avoiding getting into the weeds about. We were on an ICU call earlier this week, and literally was listening to ICU directors across the state, and the treatments for this seem to be evolving almost on a daily basis as the folks in the ICU particularly get better. So we're not specifically trying to get into the treatment on this particular call. Let me see if there are any other questions. All right, I think that's well. One question is that I'm a general surgeon, and we sort of have wonder where's all the appendicitis going, and how can we message to that it's still safe to come to the emergency room so that we don't see things in their advanced stages, and recognize that as we don't do normal sorts of healthcare, that there is a negative impact to that.
I think maybe Dr. Walker-Harris, do you want to maybe take that question with regards to essential healthcare services?
Sure.
That's an important point.
No, I think it echoes what Parham noted before, that we've noticed as well a decrease in folks accessing EMS and calling for help, and then going in for things where they really do need help. So for acute stroke and MIs. And so we do want for folks to appropriately access healthcare, but we do understand that there might be reticence to do that because of the anxiety around COVID and wanting to be as healthy and safe as possible, and then also protecting the folks that you're going back home to. And so I think that's something that we're carefully thinking through, both in the governor's office and with our partners at Virginia Department of Health and others, about what we need to do at this point with our messaging that both encourages the existing appropriate social distancing, stay-at-home orders that are in place that are working well, but reassures people that accessing healthcare when they have a need is safe to do. And so we'll be calling again on you all as our partners to help us disseminate that message, and definitely would appreciate any feedback from you about what you think might be effective messages for your particular patient population.
Thank you, Dr. Walker-Harris. One of the questions come in, and Dr. Jaberi, I think one of the UVA slides mentioned the modeling really at the local level to help with planning. So I'll defer that to a couple people who were asking that you can be able to find that information on our website a little bit later. So we're right at 8:30, which is our planned stop time. And I'm getting a note from some of the ER folks that they're saying they'll work on the messaging too, Dr. Walker-Harris, so we're happy to help facilitate that. Thank you all both very much for coming. It's been a tremendous, these webinars, I think have been a lot of positive feedback across the state, the Commonwealth, to continue to get the word out. So with that, we'll end the webinar. Thank you all very much. Have a great day. Peace out.
Thank you.